Okay, so when you start digging into pathophysiology, especially genetics, the sheer amount of detail can be, well, pretty overwhelming, trying to connect a tiny change in DNA to what you actually see in a patient.
It really can. It feels like you need a map. And that's exactly what we're aiming for today. We're doing
Mm-hmm.
a deep dive into genetic and congenital disorders. We want to lay out the essential mechanisms, the causes, and importantly, the clinical connections, drawing a lot from cornerstone texts like Porth Pathophysiology.
Hmm.
The goal is clarity.
Excellent. So we're thinking about this in three main parts.
Exactly. First, we'll tackle the genetic and chromosomal disorders themselves, where the blueprint goes wrong.
Okay.
Second, we'll look at how the environment plays a role, especially during development teratogens and such.
Right, the external factors.
And finally, we'll touch on how we actually diagnose these conditions and the role of genetic counseling.
Perfect. But before we jump into the deep genetics, maybe we should pin down that key term, congenital defects.
Good idea. So, congenital defects or birth defects are basically abnormalities in body structure, function, or even metabolism that are present right at birth. They're a major reason for infant mortality, unfortunately.
And they can be caused by genetic factors, even if the issue doesn't show up until later in life, or by environmental hits during pregnancy.
Precisely. Sometimes it's one, sometimes the other, and often it's a complex interaction between the two. We'll try to untangle that.
Okay, let's start with the blueprint then, the basic genetics. We need some core terms down, like alleles.
Right. So for any given gene, you get two copies, one from each parent. Those two members of the gene pair are called alleles. They sit at a specific spot on the chromosome called the locus.
Got it. And then there's the difference between what the genes say and what we see. Genotype versus phenotype.
Exactly. Your genotype is your actual genetic makeup, the code itself. Your phenotype is the observable result, the physical trait, the biochemical function, whatever we can actually measure or see.
And if those two alleles you have are identical, you're homozygous for that trait.
Correct.
If they're different, you're heterozygous.
Perfect. And that leads right into dominant versus recessive. A dominant allele makes itself known. Even if you only have one copy, it shows up in the heterozygote.
Whereas a recessive allele needs two copies to be expressed. It only shows up phenotypically if you're homozygous for it.
That's the basic rule.
Yeah.
We should also mention polymorphism. That just means there's more than one normal allele floating around in the population for a specific gene locus.
Okay.
And codominance, which is cool. That's where both alleles in a heterozygous pair get expressed. Think ABO blood types. If you inherit an A allele and a B allele, you don't get some blend. You express both. You're type AB.
Right, right. Good example. And maybe just underscore that a single change, a gene mutation, even a tiny one like a single nucleotide swap can have massive body-wide effects.
Absolutely. It can ripple outwards. Which
Yeah.
takes us nicely into our first big category, single gene disorders, following those classic Mendelian inheritance patterns. Let's start with autosomal dominant disorders.
Okay, autosomal dominant. So autosomal means not on the sex chromosomes, and dominant means you only need one copy of the faulty gene.
Exactly. If one parent has the condition, they have a 50% chance of passing that single mutant allele onto each child, regardless of the child's sex.
And clinically, these often look different from recessive disorders. You mentioned structural proteins.
Yeah, they frequently involve defects in structural proteins or receptors. That often leads to more systemic effects. And interestingly, the onset can sometimes be delayed until adulthood. Huntington disease is a classic example of that delayed onset.
Now, here's where it gets a bit tricky for prediction, right? This idea of penetrance.
Ah, yes, reduced penetrance. This means someone can inherit the dominant gene, but for some reason they don't actually show the phenotype. They have the genotype, but not the expected outcome.
Which can make it look like the condition skips a generation in a family tree, even though the gene is still being passed down. That must complicate counseling.
It definitely does. And then there's variable expressivity. In this case, everyone who inherits the gene does show the phenotype, but how severely? Or
Yeah.
exactly how it manifests. That can vary quite a bit from person to person, even within the same family.
Like polydactyly, someone might have an extra finger, another person an extra toe, but it's the same underlying gene causing it.
Precisely. A great clinical example that pulls together systemic effects and dominance is Marfan syndrome.
Ah, yes, Marfan. That's the connective tissue one.
That's the one. It's caused by a defect in the gene for fibrillin I, FBNI gene on chromosome 15. Fibrillin is a key component of connective tissue microfibrils, and since connective tissue is Well, everywhere.
The effects are widespread.
Exactly. You see the characteristic skeletal changes: tall, thin body, really long fingers and toes, that's arachnodactyly,
Mhm.
hypermobile joints, chest deformities like pectus excavatum.
And eye problems too, right? Lens dislocation.
Bilateral lens dislocation is common, yes, along with myopia. But the most critical, the life-threatening part, is the cardiovascular system.
The aorta.
Yes. Mitral valve prolapse is common, but the big danger is progressive dilation of the aortic root. This puts patients at high risk for aortic dissection or rupture, which can be fatal. That's the aspect needing the most urgent monitoring and management.
Wow, okay. Another major dominant disorder you mentioned is neurofibromatosis, or NF, nerve sheath tumors.
Right. Tumors arriving from Schwann cells. There are two main types, NF1 and NF2. And the underlying mechanism is really important here. It involves defects in tumor suppressor genes.
So genes that normally put the brakes on cell growth, if they're faulty, growth goes unchecked.
That's the idea. NF1, also known as von Recklinghausen disease, is the more common one. It's linked to a gene on chromosome 17. The signs you look for are things like those soft, fleshy, cutaneous neurofibromas.
And the skin spots, cafe au lait.
Yes, the cafe au lait spots. Having 6 or more of these light brown spots, especially if they're larger than about 1.5 centimeters, it's a major diagnostic clue for NF1. You also see pigmented nodules on the iris Lish nodules, and there's a higher risk of learning disabilities in certain cancers.
And NF2 is different.
NF2 involves a gene on chromosome 22. It is primarily characterized by tumors on the acoustic nerve, the nerve for hearing. So patients often present with headaches, hearing loss, tinnitus.
Okay, that clarifies the dominant patterns. Now let's switch gears to autosomal recessive disorders. The inheritance pattern is different here.
Completely different. For a recessive disorder to show up, you need to inherit 2 copies of the faulty gene, one from each parent.
And often the parents are just carriers. They have one faulty copy but are phenotypically normal.
Usually, yes, they're unaffected carriers. So for each pregnancy, there's a 25% chance the child will inherit both faulty copies and be affected, a 50% chance the child will be a carrier like the parents, and a 25% chance the child will inherit 2 normal copies.
And the mechanism is often different too. You mentioned enzymes.
Yes, recessive disorders are very often caused by loss-of-function mutations, frequently affecting enzymes. This usually leads to symptoms appearing much earlier in life, often infancy or early childhood, and the presentation tends to be more uniform than dominant disorders.
A classic example would be PKU, phenylketonuria.
Perfect example. It's a deficiency of the enzyme phenylalanine hydroxylase. Without that enzyme, the amino acid phenylalanine builds up to toxic levels in the blood and body fluids.
And that accumulation damages the developing brain.
Severely. It leads to intellectual disability, microcephaly, seizures if it's not treated. This is why newborn screening for PKU is mandatory in many places.
Because treatment works if started early.
Absolutely. Treatment involves a strict diet low in phenylalanine, and it must be started ideally within the first 7 to 10 days of life to prevent irreversible neurological damage. It's a lifelong dietary management.
Such a clear link between the enzyme defect, the buildup, the symptoms, and the treatment.
Exactly. Another devastating recessive example is Tay-Sachs disease. This is a lysosomal storage disease.
Storage disease, so something builds up.
Yes, specifically a lipid called GM2 ganglioside. It accumulates in the lysosomes of neurons, especially in the brain and retina, because of a deficient enzyme.
And the result?
Progressive destruction of neurons. Infants seem normal for the first few months. Then development stalls and reverses. You see progressive weakness, loss of motor skills, seizures, blindness. There's a characteristic finding on eye exam, a cherry red spot on the macula. Sadly, it's fatal, usually before age 4 or 5.
Just tragic. Okay, moving on from autosomal patterns, what about genes on the sex chromosomes, X-linked disorders?
Right. These are associated with mutations on the X chromosome. Because males are XY, they only have one X. If they inherit a faulty gene on that X, they'll typically express the disorder.
Whereas females are XX, so they usually have a second normal X chromosome that can compensate, making them carriers more often than affected.
Generally, yes. For X-linked recessive disorders, which are the most common type, females are rarely affected unless they inherit 2 faulty X's or there are issues with X inactivation.
So the inheritance pattern is distinct if a mother is a carrier.
She has a 50% chance of passing the faulty X to her sons, who would then be affected, and 50% chance of passing it to her daughters, who would then be carriers like her.
And if the father is affected?
He passes his Y chromosome to all his sons, so none of them inherit the condition from him. But he passes his only X chromosome to all of his daughters, making them all carriers.
Got it. Are there X-linked dominant ones too?
There are, though they're less common. They affect both males and females, but are often more severe, sometimes even lethal, in males. An important X-linked condition, though its inheritance is a bit complex, is Fragile X syndrome.
Fragile X, that's a major cause of intellectual disability, right?
It's the most common inherited cause of intellectual disability. It's due to a mutation on the X chromosome, specifically at location XQ27. It involves an expansion of a repeating DNA segment, a CGG repeat, within the FMR1 gene.
And what does that look like clinically, especially in boys?
Affected boys typically have intellectual disability, often moderate to severe. They also tend to have characteristic physical features that become more apparent after puberty: a long face, prominent jaw, large protruding ears.
Okay. So far, we've focused on single genes causing trouble. But lots of common conditions aren't that simple, are they? The multifactorial disorders.
Exactly. These are thought to result from multiple genes interacting with each other, plus environmental factors playing a significant role. The inheritance patterns are much less predictable than single gene disorders.
Things like diabetes, heart disease, but also some congenital defects.
Yes, a very common congenital example is cleft lip and cleft palate. It affects about 1 in 1,000 births.
And this happens early in development.
Very early. The defect in facial fusion occurs around the 35th day of gestation. It can range from just a small notch in the lip to a complete separation extending through the palate.
And the immediate issue for a baby is feeding, right?
Yes, difficulty creating suction. They often need specialized bottles and nipples. And management is long-term, involving a whole team: surgeons for repair, dentists, orthodontists, speech therapists. It can take years.
Right. Okay, let's shift scale now. Not just single genes, but whole chromosomal disorders. Looking at the chromosomes themselves.
Yes, cytogenetics. We can see major structural changes or changes in the number of chromosomes.
Structural issues. That means breaks and rearrangements, like deletions or translocations.
Exactly. Deletions where a piece is lost, inversions where a segment flips, translocations where pieces get swapped between chromosomes. One translocation we should mention is the Robertsonian translocation, if it involves chromosome 21.
Uh-oh, 21. That sounds like Down syndrome related.
It is. A person carrying this translocation might be perfectly healthy, but they have a much higher risk of having a child with Down syndrome because of how the chromosomes can get distributed during egg or sperm formation.
Okay, that makes sense. And then there are the numeric disorders. Too many or too few chromosomes. Aneuploidy.
Right, usually caused by non-disjunction, a failure of chromosomes to separate properly during meiosis, the cell division that creates eggs and sperm.
So you end up with cells with an abnormal number, like monosomy, only one copy of a chromosome instead of a pair.
Yes, monosomy of an autosome, a non-sex chromosome, is almost always incompatible with life, leading to miscarriage.
But having extra chromosomes, polysomy, is sometimes survivable, like trisomy 21.
Correct. Trisomy 21, having 3 copies of chromosome 21, causes Down syndrome. Other trisomies, like trisomy 18, Edward syndrome, and trisomy 13, Pathophysiology syndrome, are much more severe, and infants rarely survive the first year.
Down syndrome is the most common chromosomal disorder, isn't it? And linked to maternal age.
Yes, about 95% of cases are due to non-disjunction, and the risk significantly increases as a mother gets older, particularly after age 35.
And the physical features are quite recognizable.
They are. Often a small, somewhat square-shaped head, a flat facial profile, small ears that might be low set, often an upward slant to the eyes, a protruding tongue because the oral cavity is small, and short, stubby hands, sometimes with a single crease across the palm, the simian crease.
And increased risk for other health problems, heart defects.
Yes, congenital heart defects are very common in individuals with Down syndrome, occurring in maybe 40–50% of cases. Also increased risk of gastrointestinal issues, thyroid problems, and later in life, Alzheimer's-like changes in the brain.
Okay, what about aneuploidy involving the sex chromosomes, X and Y?
Those tend to be much better tolerated than autosomal aneuploidies. A big reason for this is X inactivation.
Ah, where in females, one of the 2 X chromosomes is largely shut down or inactivated in each somatic cell.
Exactly. It helps balance the dose of X-linked genes between males, XY, and females, XX. This mechanism helps mitigate the effects of having an extra or missing X chromosome.
So conditions like Turner syndrome, that's 45X?
Right. Only one X chromosome, no second X or Y. It affects about 1 in 2,500 live female births. The classic features are short stature, lack of ovarian development leading to infertility, and absence of secondary sex characteristics without treatment. A webbed neck in some cases.
And heart problems again?
Yes. Particularly coarctation, narrowing of the aorta, and bicuspid aortic valve are common. Management involves growth hormone therapy for height and estrogen replacement therapy starting around puberty.
And the counterpart, extra sex chromosomes, Klinefelter syndrome.
That's usually 47,000 XXY, affecting about 1 in 700 live male births. These individuals tend to be tall, often with disproportionately long limbs. They have small tests, produce little testosterone, leading to infertility and often incomplete masculinization, maybe enlarged breast.
Gynecomastia.
Is intellect affected?
Intelligence is usually in the normal range, but learning disabilities, particularly language impairment and difficulties with executive function, are quite common. Treatment involves testosterone replacement therapy.
Okay, one last genetic category before we move to environment. Mitochondrial gene disorders. These are different again, right?
Very different inheritance pattern. Mitochondria, the cell's powerhouses, have their own small loop of DNA, mtDNA. And crucially, you inherit almost all your mitochondria from your mother via the egg cell. Sperm contribute very few.
So mitochondrial disorders are passed down maternally.
Exclusively maternally. Affected fathers do not pass them on. These disorders typically mess with oxidative phosphorylation, the process of generating cellular energy, ATP.
So tissues that need a lot of energy are hit hardest. Muscles, brain, nerves. Exactly. You often see neuromuscular symptoms. And the severity can vary a lot due to heteroplasmy.
Heteroplasmy.
Meaning within a single cell or across different tissues, there can be a mixture of mitochondria, some with a mutation, some without. Symptoms only tend to appear when the proportion of mutant mitochondria exceeds a certain critical threshold.
Like having a mix of good and bad batteries, you need enough bad ones before the device fails.
That's a good analogy. Yeah.
Okay, that's a huge tour of the genetic side. Now let's shift focus completely. Section 2. Disorders due to environmental influences. Things happening to the developing fetus.
Right. And timing here is absolutely critical. The most vulnerable period is during organogenesis, the formation of organs. That's roughly from day 15 through day 60 after conception.
So exposure to harmful things during that window is when you're most likely to see major structural birth defects.
Precisely. Exposure before that, in the first 2 weeks, often leads to such severe damage that it results in miscarriage, often before the pregnancy is even recognized. Exposure after organogenesis might affect growth or function of already formed organs, like the brain, which continues developing throughout pregnancy.
And the harmful agents themselves are called teratogens.
Yes, a teratogen is any agent, could be a chemical, a drug, radiation, an infectious organism that can cause abnormalities in the developing embryo or fetus.
We know radiation is bad. High doses can cause things like microcephaly, intellectual disability. What about chemicals and drugs?
Many can cross the placenta, especially if they're lipid-soluble. The tragic example everyone remembers is thalidomide, a sedative used in the late 50s, early 60s that caused severe limb defects, phocomelia, those flipper-like appendages when taken during that critical organogenesis period.
Are there common drugs today we worry about?
Definitely. Things like certain anti-seizure medications, the anticoagulant warfarin, high doses of vitamin A derivatives like isotretinoin used for severe acne, even antibiotics like tetracycline, which can affect bone and teeth development.
Which is why the FDA has risk categories for drugs in pregnancy. From A, safest, to X, absolutely contraindicated.
Exactly. And because organogenesis happens so early, often before a woman even knows she's pregnant, the general advice is for women who could become pregnant to avoid all unnecessary drug use.
Okay. What about one of the most common and preventable exposures?
Alcohol.
Fetal alcohol syndrome, FAS. Alcohol is lipid-soluble, crosses the placenta readily, and tragically it can cause damage throughout the entire pregnancy, not just during organogenesis. Brain development is vulnerable all the way through.
And FAS has a recognizable pattern of effects.
It does. There are 3 key areas. 1, growth retardation, prenatal or postnatal. 2, CNS involvement, things like intellectual disability, developmental delays, behavioral problems, microcephaly. And 3, a characteristic set of facial features.
What are those features? You need to know them. The 3 main ones are small palpebral fissures, meaning short eye openings, a thin vermilion border, a thin upper lip, and an elongated flattened phildrum. The vertical groove between the base of the nose and the upper lip is smooth and long. Seeing this pattern is highly suggestive of significant prenatal alcohol exposure.
And the only safe amount of alcohol during pregnancy is?
0. Complete abstinence is the only recommendation because we don't know if there's any safe threshold, especially considering the vulnerability of the developing brain.
Okay. Besides drugs and alcohol, what about infections?
Certain infections can be teratogenic. We often talk about the TORCH infections.
TORCI, that's an acronym.
Yes. Toxoplasmosis from cat feces or undercooked meat. Other, like syphilis, varicella zoster, rubella, German measles, cytomegalovirus, CMV,
Mm.
and herpes simplex virus. These can cross the placenta and cause a range of problems, often including growth retardation, brain abnormalities like microcephaly, calcifications, eye problems, hearing loss, heart defects, liver issues.
Rubella was a big one before vaccination,
Right.
causing deafness, cataracts, heart defects.
Huge. Vaccination has made congenital rubella syndrome rare in places with good vaccine uptake. CMV is actually the most common congenital infection now.
And finally, sometimes it's not an exposure, but a deficiency, like folic acid.
Absolutely. Folic acid deficiency in the mother, particularly around the time of conception and very early pregnancy, is strongly linked to neural tube defects, NTDs.
Like spina bifida, incomplete closure of the spine, and anencephaly, absence of major parts of the brain and skull.
Exactly. That's why fortification of grains with folic acid was introduced, and why the recommendation is for all women of childbearing potential to take a supplement containing 400 micrograms, zero point 0.4 milligrams of folic acid daily. It significantly reduces the risk of NTDs.
That seems like such a crucial public health measure.
It really has been.
Okay, so we've covered genetics, we've covered environment. That brings us to the third part, diagnosis and counseling. How do we figure this stuff out clinically?
Right. This is where it all comes together for patients and families. Genetic assessment is the starting point.
Which involves
A really detailed family history, constructing a pedigree, looking for patterns, a careful physical examination of the affected individual and sometimes other family members, and then laboratory tests, maybe chromosome analysis, karyotyping, specific DNA testing, biochemical tests for metabolic disorders.
And then during pregnancy, there's prenatal screening and diagnosis. What's the difference?
Big difference. Screening tests identify individuals who are at increased risk of having a baby with a particular condition. They don't give a yes-no answer, just a probability. Diagnostic tests provide a definitive answer, yes or no.
So screening comes first, usually. What are the non-invasive screening methods?
The mainstays are ultrasonography and maternal serum markers. Ultrasound lets us visualize the fetus, measure growth, check anatomy for major structural anomalies like heart defects, NTDs, limb abnormalities. We can do detailed scans, even 3D or 4D imaging now.
And the blood tests.
Maternal serum markers look for levels of certain hormones and proteins in the mother's blood that can indicate increased risk. First trimester screening, often done around 11-13 weeks, typically combines an ultrasound measurement of neutral translucency, fluid at the back of the fetal neck.
Right. Increased fluid there is linked to Down syndrome risk.
Yes, and other chromosomal abnormalities. That measurement is combined with blood tests for PPPA and HCG. This combination has a pretty high detection rate for the common trisomies, 21, 18, 13. Later in the second trimester, we can measure things like AFP, alpha-fetoprotein. High levels suggest NTDs, low levels can be associated with Down syndrome. More recently, cell-free fetal DNA testing from maternal blood offers even higher screening accuracy for aneuploidies.
Okay, so if screening comes back high risk, then you consider definitive diagnostic tests, which are invasive.
Exactly. The main invasive diagnostic procedures are amniocentesis and chorionic villus sampling, CVS.
Amnio involves taking fluid.
Yes, withdrawing a small amount of amniotic fluid, which contains fetal cells shed into the fluid. This is usually done after 15 weeks of gestation. Those cells can be cultured and used for karyotyping or specific DNA tests.
And CVS?
Chorionic villus sampling involves taking a tiny tissue sample from the placenta, the chorionic villi, which shares the same genetic makeup as the fetus. The advantage is it can be done earlier, typically between 10 and 13 weeks, so you get results sooner.
Any downsides to CVS being earlier?
There's a slightly higher risk of miscarriage compared to amnio, although the risk is low for both with experienced operators. There was also some concern about a link to limb defects if CVS was done too early before 10 weeks, but that's generally avoided now.
Is there anything even more specialized?
There's percutaneous umbilical cord blood sampling, PUBS, also called corticentesis. This involves guiding a needle into a blood vessel in the umbilical cord to get a fetal blood sample. It's usually done after 16 weeks, but carries a higher risk than amnio or CVS. It's reserved for specific situations, like needing rapid chromosome results or if other tests are inconclusive.
So lots of ways to get genetic information. Karyotyping shows the big picture of chromosomes,
Right, detects numeric abnormalities like trisomies or large structural changes.
while DNA analysis can pinpoint specific gene mutations, like for PKU or cystic fibrosis.
Exactly. It allows for molecular diagnosis of single gene disorders.
And after all these tests, the results come back. Then what? That's where counseling really comes in.
Absolutely critical. Genetic counseling is not just about delivering results. It's about helping individuals and families understand the information, what the diagnosis means, the natural history of the condition, the inheritance pattern, the risks for future pregnancies, the available management options or treatments.
And supporting them through really difficult decisions sometimes.
Yes, providing accurate information, exploring options in a non-directive way, and offering psychosocial support are all key parts of genetic counseling. It's about empowering families to make informed choices that align with their own values.
That brings everything together nicely. We've gone from the molecular basis of single gene problems through environmental impacts like teratogens during that critical organogenesis window, and landed on how we actually diagnose and manage these risks clinically.
It's a huge field, but understanding those core concepts, the inheritance patterns, the mechanisms like non-disjunction or enzyme defects, the timing of environmental vulnerability is fundamental.
So, for you, the listener trying to master pathophysiology, the real skill is connecting the dots. Seeing how that FBNI gene defect in Marfan leads directly to the physical finding of arachnodactyly or the dangerous aortic dilation.
Or how prenatal alcohol exposure translates into those specific FAS facial features and the risk of lifelong neurodevelopmental issues. Or why that PKU diagnosis demands immediate lifelong dietary changes. It's about linking the why to the what you see in a patient.
That really grounds the theory in practice.
Definitely. And maybe one final thought to leave you with. We talked about advanced maternal age, increasing the risk for non-disjunction and conditions like Down syndrome. We also know there are genetic risk factors linked to later onset diseases, things like Parkinson's or Alzheimer's, which are often associated with aging. So,
Where are you going with this?
well, as our ability to screen for genetic risks becomes ever more sophisticated, how might this change things? How will these evolving tools impact not just prenatal decisions, but maybe lifelong health planning and risk management for everyone across the entire lifespan? Could we see a future where genetic profiles guide preventative strategies from a much earlier age?
That's definitely something to think about, the long-term implications of decoding our blueprints more and more accurately.
Food for thought.
Indeed. Well, thank you for walking us through that complex landscape, and a huge thank you to you for joining us on this deep dive from the Last Minute Lecture team. Thanks for listening.